Samuel, and I am an internal medicine and pediatrics resident at the University of Illinois College of Medicine in Peoria. I worked along these fine resident physicians, Doctors Rose Chisenga, William Kim, Tesneem Adenwala, and Daniel Majuni, to present to you a case of lung cancer with skin metastasis. I'll start off by saying that lung cancer with skin metastasis is very uncommon. If skin metastasis is found in the absence of respiratory symptoms at diagnosis, this often means the disease is more aggressive and often has a poorer prognosis, which was the ultimate outcome of our patient. Our patient presented as a 55-year-old male with a strong history of tobacco use that initially presented to an urgent care facility about 2 weeks after noticing a painful nodule on the right upper back. He ultimately had no respiratory symptoms at the time, and rest of review systems was negative. He was initially trialed on oral antibiotics after having fine needle aspiration done on the nodule. Aspiration did not reveal any conclusive results, but the nodule continued to grow and eventually ulcerated as seen in Figure 1. 2 weeks later, the patient had an excisional biopsy of this lesion. Biopsy revealed a metastatic, poorly differentiated squamous cell carcinoma confined to the dermis and subcutaneous tissue with no epidermal dysplasia. This raised concern for a non-cutaneous primary malignancy. After this, he subsequently developed fatigue, poor appetite, and weight loss to the point that he required hospitalization. This was all within 2 months of noticing the skin nodule. When the patient was hospitalized, initial physical examination was unremarkable with the exception of a well-healing post-excisional wound as seen in Figure 2. His lab work was significant for an elevated serum calcium to 16.3 and an elevated parathyroid hormone-related peptide to the level of 32. CT scan of his chest showed a 9.5 by a 7.6 centimeter hilar mass on the right and mediastinal lymphadenopathy, which can be seen in Figure 3. Patient received bronchoscopy with endobronchial ultrasound, which confirmed mediastinal lymphadenopathy, but it also revealed multiple fixed, ovoid, shaped friable vascular lesions in the left and right mainstem bronchi. Biopsies of these lesions confirmed primary squamous cell carcinoma of the lung with cutaneous skin metastasis. Further body imaging of the patient did not reveal any other metastases. After the patient's complete workup, the final diagnosis was squamous cell carcinoma of the lung with cutaneous metastasis, as well as hypercalcemia of malignancy. While in the hospital, the patient did receive IV fluids, zoledronic acid, as well as other supportive measures. The patient did improve symptomatically and his hypercalcemia resolved. However, the patient still had poor performance status, which would not make him a proper candidate for chemotherapy. Eventually, the patient entered comfort focused care and was discharged to hospice. For our discussion, it is important to mention that cutaneous metastases of lung carcinoma have a reported incidence of about 1 to 12%. It has been shown that all histopathological lung carcinoma subtypes can metastasize to the skin, but most commonly are adenocarcinoma and large cell carcinoma. Oftentimes, cutaneous metastases of the lungs are poorly differentiated and oftentimes are typically confined to the dermis and subcutaneous tissue, as seen in our case. Ultimately, in our patient, it was the skin biopsy that led to the final diagnosis of squamous cell lung adenocarcinoma. Thus, immunohistochemical analysis of both lung and skin biopsy samples is essential to the final diagnosis. As I mentioned, lung carcinoma with cutaneous metastases are very aggressive, and patients usually only live 5 to 6 months after their diagnosis, while those patients who present with respiratory symptoms often have a better prognosis. While the skin biopsy is what led to the patient's diagnosis, this atypical presentation posed a diagnostic dilemma and may have delayed timely care. This highlights the importance of age-appropriate low-dose CT chest screening for the early detection of lung carcinoma, which unfortunately our patient never had. In conclusion, skin metastases without bronchopulmonary symptoms can be the initial clue to lung primary cancers, but this is very uncommon. When this is in fact the case, these are usually more aggressive cases of carcinoma and have much poorer prognosis. Our references are provided below for our viewing. This concludes my presentation. Thank you very much.